So I'm going to move to talking about treatment. And I just want to bookmark that we'll talk about U equals U sometime during this treatment thing. Because I think it makes sense to now kind of talk a little bit more about the treatment landscape. Maybe, Eric, you could like set the picture, and then we'll go through some more specific things. But maybe you could set up where we are.
Yeah, I think when I think about the treatment landscape, I still think it starts at the beginning. And it's worth reminding everybody that after decades of debate as to when to start, I think everybody completely agrees that everybody diagnosed with HIV, regardless of CD4 count, regardless of symptoms, regardless of comorbidities, should be offered and encouraged to initiate antiretroviral therapy. And that's because we now have convincing data showing that it prevents disease progression. In addition, we know, and we'll talk about U equals U, that it prevents transmission. But probably as important is it's just so darn easy to do. The treatment now, most people, we start on 1 or 2 relatively small pills often a day with virtually no side effects for the majority of them. So the decision about when to start is very straightforward. Obviously, we need to help people get prepared to take their meds consistently if they're dealing with psychiatric disease and substance abuse and things. But so we should start everybody. And when we start, the guidelines, there's increasingly a consensus in the guidelines, both US and Europe, that most recommended regimens are 2 nucleosides and a third drug, and the third drug is essentially always an integrase inhibitor. And the most recent guidelines, and we may go over this in more detail, have really focused on 2 of the more recently approved integrase inhibitors that are small pills, don't require boosting, so you don't have to worry about drug-drug interactions, generally very well tolerated, and happen to have a high barrier to resistance. So even if things don't go right, resistance is very unlikely to occur.
Sure. And in many ways, I think, as the guidelines become more and more small in terms of number of recommended regimens, it's getting easier for people who, unlike ourselves, may not have been doing this all their lives and have always been put off by it. Because the guidelines used to have so many different options that it looked too confusing, and the guidelines were so expansive. In younger people now who are thinking about getting into HIV, the treatment has become simpler. And I think it's all become good. The downside on all of those regimens is really pretty small.
Sure. And one thing about treatment initiation is how quickly should we do it? We've lived this to you, Paul, to talk about this. It's a thing.
It's a thing, right. Historically, there was this whole idea that before people started on ART, they needed to go through a little educational course, an HIV 101 course to learn about the importance of adherence and what viral load and CD4 mean and all that stuff. Well, it turns out that was all garbage. It really
it wasn't at the time.
No, I think
there's a little garbage.
One of the most remarkable moments I've experienced recently at a major meeting was I was watching my colleague Serena Koenig present a study that they did in Haiti, where they basically took people who were newly diagnosed and they randomized them to start that same day they got their diagnosis, or to go through this little HIV 101 course and then start. And it turns out that the DSMB stopped the study early because the people who started the same day did clinically better.
Right.
Survived better. And it turns out we can do that with our treatments now. People want to start treatment right away, and there is no reason to delay. In the vast majority of people we see now, we give them a prescription for ART the first day. One thing I will mention is that transmitted resistance, which is a big fear, is significant enough to impair the activity of a bictegravir or dolutegravir containing regimen. Vanishingly rare.
Right.
Vanishingly rare. Right. So go ahead and start, and you can still give them the HIV 101 course, but after they're on ART.
Right. So there is certainly paternalism or maternalism in our readiness to prescribe therapy early on. But I would say that still counseling people about the importance of adherence is crucial. And I would also say that there's no urgent need to start everybody on therapy the day that they're HIV diagnosed. I think the studies that are done in Haiti or other developing world scenarios, there's a high loss to follow-up rate. Folks are presenting very late in the course of their disease, and they often travel a long distance to get to the HIV clinic.
That's true.
So some of these issues are less important. We're going to come back to U equals U and treatment as prevention. We want to get people on therapy quickly to get their viral load undetectable as rapidly as possible. But if somebody comes in and says, I don't think I'm ready to start this, I don't think we should be twisting their arm to get them
it's a
to start
general
on
practice.
therapy.
General
right
practice.
away.
I agree with you, we shouldn't
so
twist their
it's-
arm, but I think, a lot of that
should
comes
talk
from,
them into it.
from the prescriber
Yes,
side.
we should be
not
talking
from
them
their
into
side.
it, but,
Because
it's
what other
okay for
STI
people to walk out of the
what
office
other
without a
STI
prescription.
do we ever say, come back in 3 weeks and we'll see if it's still there?
Yeah.
Until
Yeah.
it gets really bad. What, do we do that with hypertension, diabetes, hypercholesterolemia?
We don't start people on antihypertensive therapy when their first diastolic blood pressure is 92.
Right.
They come back.
Diabetes might also be the best example. But
If it's discovered and discovered is it is diabetic,
Sure.
then you don't wait and say,
sure,
let's wait
you
to
don't
get
wait
worse.
to start treatment, sure.
Yes, there are challenges, but most of the time they can be overcome.
Sure.
I know in some regions we don't have them, we don't need them. Some places there are starter packs that people have access to 10 days of therapy. It does make people feel better to start sooner rather than later.
I think my point was kind of like you do have to have your clinic or office set up to do that,
Right.
and if you can do it, it's great. If it's a few days later, that's okay. But it's this idea of it's an important problem.
One thing just to mention about San Francisco's experience, because they didn't do a randomized study, but they have this historical data, and what they've shown importantly is that this process of starting ART right away has led to a much faster decline in HIV RNA, faster time to undetectable, but importantly, no increased risk of resistance. That's over time.
Right.
Looking at their historical data, it's not like they've lost anything by doing it.
But they also were using two very, very potent regimens, though, bocedurenavir or dolutegravir exclusively for that study, though, too. And you wouldn't expect resistance if they even failed.
Well,
That's
that's
what we
the
got today.
advantage, right? That's the
Because we
advantage, and
can.
that's why we can do this, and we don't have to worry about hepatitis B. We can wait for that test to come back and that sort of thing.